Hello, everybody. Welcome to this webinar hosted by Moondance Cancer Initiative. Today we'll be having a conversation about digital solutions for cancer care. I'm delighted to be joined by our two experts for the afternoon. First up, Jonathan Gregory is a former consultant cancer surgeon and MDT lead. He now freelances to bridge the gap between medicine and digital solutions, working with diverse teams from Imperial College London to AHSNs. On my other side, Helen Northmore is part of the TEC Cymru team, supporting the scale-up and adoption of technology-enabled care in Wales, and has significant experience here through teams such as in DHEW. So, welcome both.
Thank you.
Thank you.
For those that don't know Moondance Cancer Initiative, we are a philanthropically funded non-profit looking to find, fund and fuel brave people and brilliant ideas to accelerate the adoption of improvement in cancer care in Wales. Last year, we commissioned John to author a report for us on digital solutions for cancer care. We've been aware that it's an exciting field and a fast developing one with a lot of potential, but also a complex one. And so we commissioned John for his expert view on what was exciting and what could really make a difference to cancer care. Following on from that report, we're here to discuss some of the most exciting elements and how that might be implemented in Wales in the nearby future. If I could just put one quick reminder in, we're going to be having a Q&A session at the end of today. Please do put your questions in the Q&A tab, which you should see in Microsoft Teams. You can upvote other people's questions if you are interested in them, and we'll get to that at the end of our session. So, John, Helen, to start off, we're going to talk about screening. Screening services are absolutely key for cancer detection, as you well know. However, in Wales, there are issues surrounding lower adherence rates in more deprived populations, difficulties in communicating complex public health messaging. John, I'm going to throw over to you. What sort of solutions can digital platforms offer in terms of supporting screening services?
I think out there's lots of different solutions, and probably the starting point is trying to identify what the main problem is with uptake in your area. So, you know, is it a particular population or is it across a whole body of people or particular tumour sites? I think, as we'll come to a few times in this, it's trying to focus on the problem first, and in a way the solution hopefully starts to come into focus. So we know there's evidence of improved uptake in screening from simple measures like a text message 2 weeks after a fit test has been sent out, or you can have, you know, adjustment to uptake in cervical cancer screening. But when you look at those studies, often it's sort of having an effect in subgroups, not necessarily over everyone. So I don't think there's necessarily a cheap, easy solution that fits everyone, but equally, you know, a 5% increase return in fit testing for first-time testers is a lot of people for a measure that is inexpensive and easily scalable. So I think there's things like that, through to perhaps more complex interventions where you're trying to focus, you know, if you've got data to support engagement with a particular group of people who are seldom heard or find accessing services more difficult.
Are there any technologies you'd like to talk about, particularly with the issues around capacity and do not attend rates?
Yeah, so I think that's one of the challenges, isn't it? Is we've still got some people not engaging with screening services, but also screening services are under a huge, huge burden. So there are, you know, a company called Deep Medical that uses AI to look at DNA rates in clinic attendances, investigation attendances, and there'll be other companies out there doing similar things. But I think ways of using the resource you have more effectively. So I think there are tools out there using digital or AI solutions that at least can help, you know, map demand. So, for example, Deep Medical, they've got 92% accuracy at predicting DNA rates for outpatient attendance 2 weeks prior. You know, they model on distance to travel, weather, and these things. And I say there'll be other ways, but I think some of it is it's a crying shame to have screening services there and patients not turning up for appointments. So there's two sides, isn't there? Capacity and making sure there's demand by getting people to engage. And
as we evolve these services, I suppose that has implications for how we communicate with the intending recipients of screening. Helen, would you like to take that?
I think most of the audience here will be aware of the issues that were experienced in the media, particularly around a decision by Public Health Wales to reduce the frequency of cervical screening in Wales. And I was quite excited about that decision because it's the first example that I've seen where personalised medicine is starting to come into screening services, where it's possible to identify higher risk patients and lower risk patients, and you can then tailor services to your risk level. However, that wasn't communicated well, and we all are also because it's the first time, and NHS services and particularly screening, the culture has been everybody gets the same, everybody has to go and do this. It's a one size fits all kind of message. And digital technologies and data and analysis is enabling us to look at doing things in different ways. But I think that's going to require a considerable amount of communication to change how we expect to access health services. And that's going to have to be not just for screening, but around how we do a lot of things. So I think it was unfortunate that they were trying to do the right thing, but it's the first time, and so there was that sort of big change in culture and perceptions. And I think the other point that you were making about sort of different channels and tools is more vital than ever. I mean, previously, it would be posters on a bus, and you'd see leaflets at your GPs, and that's a public health communication campaign. Whereas now we have to use so many different channels to reach as wider audience as possible. So I think that there's these huge opportunities, but how are we going to communicate and change the culture? It's a big job.
John, I think picking out one technology in particular, you raised in your report for us, text messaging as a sort of low resource way of engaging screening participants. Could you speak to that?
Yeah, there's been work done about where the text message should come from, where the content should come from. So that sort of sense that most of the public really trust their general practitioner, and so having messaging appearing to be direct from the general practitioner increases response rates. I'm not sure, if I'm being honest, we've yet worked out the content exactly to drive the behaviours. But I think it's like, but if you look at the work from even from Staffordshire, they increased breast screening rates via a Facebook page. So I think what I'm keen to stress is, whilst there's some AI, very complex ways you can do this, there's some simple, cheap, very scalable ways that we're talking about common cancers. We can make a difference with actually some quite low-tech solutions. And to Helen's point, really around messaging, I think there's also a need for us to understand the value proposition to people who are being welcomed for screening, isn't it? We've got to convey the benefit sufficiently well for it to speak to them as a reason to engage. And I'm not sure that one size fits all doesn't always work. Again, we have an opportunity to segment our messaging.
And I think it's also look at how other parts of the service. I mean, text messaging for outpatients appointments has been common for a long time, and other services from GPs, flu vaccinations and so on, have been reminders have been delivered through text messaging. So it's taking the learnings from that. So much of what we've just talked about is about psychology, and it's understanding the psychology of how people respond to messages. Which other services have got much more experience. How can we apply that to screening?
And Helen, I believe there are some practical examples of this sort of intervention text messages in particular in Wales already.
Yes, so a number of health boards use products like Doctor. So Aaron Bevan has been using that for outpatient appointments and reduced the NAs through that for a long time pre-COVID. Swansea Bay have been using Doctor in a way to check in with their waiting lists, to see who was still requiring treatment after sort of the long break over COVID. So there is plenty of examples, as the point earlier, that we are using those techniques, and so it's trying to distill the learnings and apply them wider.
Absolutely. Thank you both. Moving on to primary care as the other sort of primary entry point for cancer diagnosis. Primary care have the unenviable task of both detecting rare cancers which are coming through, for instance, GP practices, whilst not overwhelming secondary care with the number of referrals that they send through. If I were working in a GP practice, how would I be looking to use digital tools to help my cancer detection? In particular with, John, I think you want to talk about data coming out of a GP practice.
Yeah, I think as with the last point, really, it's trying to understand your practice and your geography. And, you know, I accept the challenges of healthcare data, so I'm not sort of naively saying this, but if you can understand, you know, are there particular cancer pathways that you as a practice, as a health board, you know, don't recognise the symptoms so well or have an issue with, or, you know, are your patients engaging with you in primary care at later stages of disease? So I think that point about if you're able to mine your data a little bit to get some insights, because I don't think it's going to be universal that across every cancer pathway you're equally bad and the problem is the same. I think it will be different as we go across the different pathways. And if you can understand that, firstly, there's learning opportunities, because it may just be that the practice down the road, or, you know, they are the flip of that. You know, we're great at recognising skin cancers, but we're struggling with lung, and they say, is that issue one of the clinical behaviours or clinical organisation, or is it the population you're serving and the messaging and the? So I think the first part is understanding the problem. I think then there are, again, solutions out there. And yes, I was a secondary care clinician, so it was much easier for me to work through a pre-sieved selection of patients. But I think, you know, we can talk in depth, but, you know, whether it be interrogating blood tests, whether it be looking through data sort of on your system of your patients to just flag people at risk, or is it, you know, products such as See the Signs that can almost do both, give you sort of metrics about your referral patterns and outcomes, and some nudges or warnings that you may have an underlying cancer for the patient.
I think in what's probably going to be a repeating theme of today, a key message there is to start with the problem, not start with the solution, and that's something you're quite passionate about, Helen.
Absolutely. I mean, I think we are all guilty of it, that it's look at I found this lovely solution. We haven't really established if that's the fundamental, that's going to solve your fundamental problem. I think, you know, when you're talking there about using data to identify those sort of maybe gaps in expertise, well, then you know what your problem is and you can look for a decision support tool, which, you know, for that particular area. But too often people will go to a conference or see something online and go, oh, that's a decision support tool for this particular thing, not realising where they stand in terms of that benchmarking on being able to identify, you know, whether they need it or not. And I think it's very easy to look at the shiny toy is going to make my life easier, but actually, if you don't know what is making your life difficult, is that the best use of your money to go and buy that thing?
And John, could you speak to, in a hypothetical situation where you've worked out one of your problems being, for instance, cancer detection of a certain site, could you set out some of the potential benefits of some of these tools, for instance, decision aids, blood tests, etc.?
I think, yeah, if we know that, because I think there's likely to be different ways you're making mistakes, and they're honest mistakes, aren't like over referring or under referring. And so I think certainly there are tools out there that can help you nudge one way or the other. I think there are tools, and I think some of this is having conversations within a health board about, because, you know, secondary care have limited capacity for certain investigations compared to others. The importance of how narrow you make the funnel varies probably across cancer types, doesn't it? And, you know, your vague symptom pathway, how are you managing that group? Because it doesn't necessarily help the system if you have some very tight referral decision tools for the big cancers, and then with a huge swathe of people who are in a vague symptom pathway that just sort of overload the system in another direction. So I think there's, things like Pinpoint Health that, you know, if you're a practice that has a lot of blood test data, and that can give you some decision support, really just giving you the chances of it being cancer or not cancer. So it's not telling you it is, it's not saying you must do something. but it's perhaps helping you to sharpen that decision boundary about I'm going to refer or not. Through to, say, see the signs, which are perhaps more around the history and around performance and giving you insights about your referral practice. And most people respond, you know, what you get the Hawthorne effect of being watched. Knowing you're being watched, you slightly sharpen. But I think we shouldn't look at this as clinicians negatively, because you might just get data that says you're doing a brilliant job. And, you know, we don't often get told you're doing a great job, but maybe you are. So what, you know, if we've got to get better, let's get better. And if not, let's celebrate the great job you're doing.
Something you wanted to talk about today, and I think this is probably going to go out to all the GPs in attendance, is the phenomenon of alert fatigue.
Yes.
Can you speak to that and how we can try to work around it?
Yeah, I mean, I've in recent weeks been in many meetings with general practitioners, and you know, their systems already have a lot of alert warnings on for the multitude of health conditions. And I think this is the importance of, in a way, understanding your workflow. And because again, even if, you know, down the road, Helen's a GP, she's got a product and it works great, but maybe that's because Helen works in a different manner to me, and the way that product would interact with my clinical workflow would just be annoying. I'll turn the alert off, it's in the wrong place. So I think there is an absolute challenge here to get the messaging, you know, the right message at the right time. It doesn't help us to just have messages that, oh, I've just got somebody else bleeping and I've got to override it. But there's enough solutions out there, I think, for GPs to not be picky, but, you know, to actually say, I'm sorry, that's not going to work for me, but is there something that can fill my workflow like that? So I'd sort of encourage them to not despair, really, that they don't have to drown under alerts.
I think also, and following up on that point, be brave when going to the market. You know, you are the purchaser. Too often you get told this solution will do everything, and you're actually, yes, but I don't want to do everything, I want to do this. And they look like big shiny companies, so you think it will work. It's you are the purchaser. You know, you have the power in that conversation. Having that clear idea of what your workflow is and what your problems are means that you can go out with a specification that says, I need this in the product that I'm going to buy, and it will help you make a better purchasing decision. So it will fit within the workflow. I mean, we've been doing some work at TEC Cymru looking at how GP practices have been using e-consult. You know, one product rolled out in one, you know, same to everybody. Huge variety in how it's being used. Some people have completely changed their model. Some people don't like it. So because it's just one size fits all, as opposed to being able to go, this is what I need. I will go and buy the thing that will work for me.
GPs, especially being such local care providers, it's not difficult to imagine how the care needs and the cancer detection needs of each GP are going to be different, and therefore all quite different solutions. Moving on down the diagnostic pathway now, there's a lot to talk about here, but moving on through the main workhorses of cancer detection, cancer diagnosis, being pathology, radiology, endoscopy, all of which are discussed at the MDT. Almost all of these services and settings are struggling at the moment with demand and workforce issues in particular. If I was sitting coordinating on an MDT, John, where might I look for digital tools to help me with that workload?
Yeah, I mean, as you're absolutely right, James, that there's almost so many that you think, oh, where do I start? And again, are they all going to help you? No, they're not. So aligning, I think radiology have some of the most advanced tools, and we can talk about some specifics if you wish, but I think there's certainly some radiology tools there that can help. Pathology, lots of work in pathology. But again, I think we're still probably we're not yet at mass rollout, but we're certainly developing products. And then in terms of MDT support, you know, I do think there's some products there that can be used in the very near future to support MDTs handling the case volumes, trying to, you know, reduce that waste, waiting, and critically variation. You know, MDTs vary in the device they give for patients with the same stage of disease. Some of that is warranted variations based on, you know, patient factors, but some isn't. It's just based on exhaustion during an MDT with too many patients on it. And I think we would all accept that we've got to do something to at least address that, because standardization when appropriate, you know, is generally more efficient, safer. So that would be my take across that.
Carrying across the MDT support software, there was a platform that you picked up on, Deontex, for this report, which is really evolving the way that digital tools can support MDTs. Could you speak to that functionality?
Yeah, so Deontex received an NHSX AI award, and they're currently being evaluated. But essentially, the platform captures patient information for that case. Interestingly, there's an ability for patients to put preferences onto the platform, you know, to do with what the benefits have to be for treatment for them to accept it. But then it's a guideline-based AI algorithm, so it's entirely explainable. It's not black box. You have your local guidance, you have national guidance, and the algorithm essentially matches the patient down the algorithmic pathways. So this isn't some scary AI, it's for decision support in that way. So that's currently being trialled for high volume MDTs such as prostate, where there is an ability for some cases to very much algorithmically manage them and to have those, I don't like to use the word simple, but should we call it more predictable cases, can be managed actually in a mini MDT where it's really the decision support, 1 or 2 clinicians rather than all the clinicians, freeing up, you know, cognitive bandwidth for the wider MDT to talk about the complex cases where actually there isn't, you know, there's equipoise about what's the right thing to do. And I know they're even starting to look at disease trajectories and trying to give that sort of sense of alternative futures. So if you have a patient with these parameters, treatment X will deliver this and would be anticipated to do that. And that really gets us very much into informed decision making, doesn't it? Shared decision making. So the product is in evaluation and rollout, but there's that product and others that I think could be genuinely revolutionary for MDTs.
I think there's a range of technologies that are looking at imaging and diagnosis, and particularly using AI and it's to this point about the simple cases. It's how can we save the people for the complex, and how can we just how can we make it easier for the simple decisions and reviews to happen, which don't need that sort of we don't need that sort of necessarily even human looking at whether this is, looking at what the results are, because, and there's a number of factors, and it's, yes, we don't have enough people to do the imaging and the assessments, and that's not going to change anytime soon. So this is a way to try and sort of increase demand, but also that's not necessarily the job people want to do. So we talk a lot, I always use the phrase, machine learning can set us free, because it means that we can deal with people. And there's a range of products that are in development, different stages of development. They're all focused on this area because a lot of this work is more routine and can be, turned into machine learning.
And this is an evolving field in Wales, am I correct? We were talking earlier about application of AI in radiology in Wales in mammography, is that correct?
Yes, so talking of the AI competition, a company called Chiron Medical went in round 1, and they're actually working with Breast Test Wales to test their MIA product in mammography. Again, looking at, sort of taking a huge store of images, understanding and learning from those images so that those simple cases, the ones where it's very clear, can be assessed that way, saving the assessment, the more complex cases for more detailed assessment.
Sorry, I think what's really interesting though with particularly those products is you get a human computer check and balance. So there's some evidence that in some settings the mammography is better at picking T1 cancers than humans. Now those are the patients with tiny tumours that have the most to gain from screening, and so it's about learning to work in harmony, isn't it, and going, oh okay, rather than a sort of us versus them, isn't it?
I think there's been a lot of concern. Does this mean I'm going to have a job in 20 years, in radiology and radiography? And I think there's no concerns about that. I think there's such the amount of imaging that is happening is increasing year on year because we have new tools to look at cancer detection in a new way, and that's just creating increasing amounts of images. So we cannot, recruit and train enough people to be able to assess all these images. So we have to look at another way of doing it to have the information for the MDT.
Yeah. Something that's been touched on lightly as we're discussing some of these solutions is how you design services around them. And I think this is a really key message of today, in that it's not just about the product, is it? Could you speak to how you could start to thinking about designing a cancer pathway around these technologies?
Yeah, I mean, you're absolutely right, James. If you have a broken pathway and you put a digital solution into it, you're just going to have an expensive broken pathway. I think it's taking a step back and almost using, sort of values-based healthcare methodology, map your current pathway from the moment the referral lands in your department, and even consider how it lands and what's in that referral. Map the touch points that are human touch points, the touch points that add value. What does the patient know at each touch point? And are they getting? And when you strip out, that often points to maybe a 20-stage pathway, of which only 10 steps add value, of which the patient's only seen 3. But you can start to look at that pathway, identify some waste to take out. You'll identify the bottlenecks. Because if you've got the number of days, why does it take this many days? And then that starts, I think, to help you go, so how do we breach that bottleneck? And is the answer just redesigning the forms we use? Maybe it doesn't need digital. Can we redeploy people? Or actually, there's a digital solution that will widen that bottleneck. You just have to be slightly mindful of what your downstream effects. It's a slight cliche, but you do have to plan for success. If it's a bit like if AI mammography starts detecting loads of cancers that we were missing before, is there enough surgeons to operate on them? So you do have to just always have one sense of, if we succeed, are we ready for that? Of course you might not, but
we're back to what's the problem.
Absolutely. Before we move on to the next section, I'd just like to remind everybody, if you have any questions for John or Helen, please do fill them out in the Q&A section. We've set aside some time to get to those and hopefully get a real conversation going about the priorities in this room. Moving on to a new digital technology, which is really came to the forefront through the pandemic and in 2020, of remote monitoring for patients in their own homes with chronic conditions as in the heat of the pandemic, a way of freeing up hospital capacity. There's some discussion now about whether it might be a sustainable, patient-centered way of taking care forward. And Helen, I could wonder if you could speak to some of the potential benefits of these platforms.
As you say, we saw an explosion in the use of remote monitoring platforms in a range of use cases, but particularly focused around chronic condition management and a large amount of COVID-19 pulse oximetry at home in particular. And the focus was to again, move us towards that more personalised medicine, the right intervention at the right time. So in chronic condition management, the traditional model is you have an appointment with your consultant every 3 months and you review the results of your latest test, and then you have a discussion about what the next 3 months or 6 months or a year is going to be. And that is not picking up the people who need interventions earlier, so they end up quite often with unexpected, unplanned hospital admissions, or those people who are fine with how their condition is managed and are taking up resources within the NHS and their own resources in order to do that. So there's very clear benefits about how being able to monitor your condition at home and share that information with the clinicians can lead to more timely and appropriate levels of intervention and support. And with COVID-19 in particular, there was, because of the pulse oximetry at home, it was really important to understand, particularly with COVID-19, when oxygen levels were dropping, so that it was the right time to come into hospital. Again, that focus, when is the right time to have an intervention? So this can fundamentally change, particularly outpatient models.
Do we know how patients feel about this? What their outcomes are like when they're receiving that sort of care at home?
So there's been a number of pilots in Wales that have looked at this, and actually all of the patient reported outcome measures are really positive. People feel that they are able to take some control and actually have a say in how they feel and how they are managing their condition. There was a pilot in Cyntaf Morgannwg of the product and Betsy Cadwaladr looking at heart failure patients, and there was clinical outcomes that were people were able to be released from hospital earlier. There was avoided hospital stays for a number of patients, but actually they felt in control, and that's quite a fundamental shift in how we've traditionally delivered healthcare services, which is very paternalistic. Your doctor will tell you how you're doing and what you need to do, and how you should feel, whereas actually this puts the patient much more in control. So hugely positive benefits. But I think Jonathan and I were having a bit of a discussion earlier about how that's wonderful. I mean, absolutely wonderful, game-changing, life-changing for patients. But there's going to be a lot of consequences in thinking of the unintended consequences of how do we deliver to the maximum benefits of this technology. It's about really fundamentally changing our pathways and how we resource and support condition management. But I'm sure that you've got some feelings on that.
Yeah, well, I think it's, as we said, some of this is the pandemic was great for the acceleration, but I think there's a need, isn't there, to just ever so slightly pause and consider what are we trying to gain from virtual wards, home monitoring, distant monitoring, isn't it? And if it's to create space in hospitals, well, have you got sustainable model of staffing that, who's responding to the alerts, who's monitoring that? So we've got some issues there that until you have AI platforms or whatever, you've got a fixed workforce. I think we talked like the sort of where's the benefit and to whom, and you alluded to this, Helen, isn't it? Is the benefit could be more efficient care or more efficacious care. Or it could be the same care, same cost, but the patient experience is enhanced. And we've got some evidence that patients who engage, or are asked to fill in patient-reported outcome measures during care of cancer have better outcomes just from, I guess, feeling slightly more listened to. So depending on what you're doing, and they say what you're aiming to do, gives you what product you're looking for. So whether that's really a sort of patient experience, patient-reported outcome measure, communication type product, such as Careology, through to actually it's more about physiological monitoring and really hospital at home. They're different. And I think that, there is some unknowns in here. The NIHR have got a call out at the moment for rapid evaluation of physiological monitoring solutions. And you look at that grant call for teams, and it's really clear from that we've got to work out the health economics of these. We've got to look at the benefit, who's benefiting when and where, and because they don't map in quite the same way as a historical, here's a medical device, here's a new drug. And I think the system's just going to take a little while to piece together that it'll be lots of little benefits that overall are probably a big benefit, but if you don't capture them all, some of these advances don't look quite so appealing in a business case.
And I think also that this technology has the opportunity and cost and challenge of potentially breaking down what are sometimes quite siloed between secondary care and primary care.
Yep.
So a lot of people with chronic condition management are actually observed most frequently at their GPs. Then also if these people are receiving social care services and actually have monitoring at home. So there's lots of telecare providers who say that they can deliver telehealth services. They're trying to move into that space because it's the same technology, but it's not the same space because it's used in very different ways. So it is a transformative technology, and I don't think we've worked out how to make the most of it and the impact it's going to have. Where is it going to put the burden of the clinical work? I think is the question that hopefully will start coming out of that competition.
So very much with that philosophy of understanding your problem, again, before you go to the solution. With that in mind, John, could you spell out some of the potential benefits in a cancer-specific setting of some of these platforms?
Yeah, I mean, I think probably one of the most advanced things would be managing patients having cytotoxic chemotherapy who are at risk of neutropenic sepsis. we're moving into the realms where actually we can offer some monitoring of people like that at the point of their sort of nadir of their chemotherapy. But that merged with some of these point of care testing options like NutriCheck or other, where we actually can get some observations and a neutrophil count. Well, in the right setting, that means we can keep vulnerable patients away from hospital or expedite them getting the treatment they need. But back to understanding the whole pathway, it doesn't help us if the patient has some remote monitoring, has vital sign deterioration, does a NutriCheck that shows they're neutropenic, and then end up sat being treated in an A&E for 8 hours. That probably is not help. They needed to be steered, directly to an oncology ward. But that's the pathway change, isn't it? That's harder than just getting some remote monitoring and getting a finger prick blood test.
Fantastic. Well, thank you so much for that discussion. We're going to head into the Q&A in a session, but I have just one more question for the both of you. And this one is less about the technologies themselves and more about the doing, the implementation. Both of you in your roles work with multiple medical and digital teams to implement digital solutions in their healthcare settings. In your experience, what are the ingredients for a successful outcome? What do people who want to implement these solutions need to do in order to move towards success?
I think taking a step back and a deep breath before you begin. It's as clinical teams and clinical managers so desperate to solve the current crisis, the current problem, that often you delve straight in. I mean, you call it solution focused, don't you? And it's absolutely that. Try and hold your nerve for a moment and get data. Do that piece that it seems like it's from industry, but that piece about speak to some of the stakeholders in this, because there's no point in you going, we'll have this solution if half the team are not convinced it's not going to work. It's not. So try and hold your nerve, and that time in reconnaissance is never wasted sort of motto. So get data, identify the bottlenecks, map your process. And then I think it's the, as it always is, isn't it? It's the people engagement piece. But in that, we mustn't forget, a lot of these technologies are subtly moving work to patients and carers. That is the only way you scale these sort of technologies, but they have to be in the room. There has to be some impact assessment for that group. I mean, Helen, I don't know your views, sort of trying to bring change, digital change into systems.
Well, I would add quite small practical tip: talk to your information governance team, early, and informatics, because you might have worked through your problem, your workflow. You might have identified the right solution, or you need to work with the procurement team up front to make sure that you've done that in the right way. But those are the bits that take time. It can take months to get IG approval around integrating new technology or implementing technology. So, that's when people get frustrated. So people and culture is not just the people within your team, it's the people within your organisation, to make it, to get them on board with what you're trying to do, and to help and to use their expertise up front, because the worst thing that can happen is you've gone this far down the pathway and then you go to IG and they go, oh, hang on, what is this? And
I'd add almost, I think clinicians are susceptible to this. Most of us like to do new things, whether that be a new research paper or a new thing. So there's the tendency, me first, and actually just have some conversation. Because if someone down the road or north of the country has done it already with the product, there's no better idea than a stolen idea. Take what they've done, you'll be able to deploy it so much quicker on the background of their learning, and you can then move on to the next problem. So I'd encourage that sense of you don't have to be first.
It's the problem you want to solve and the people you want to solve it with. That's what I'm hearing.
Yeah, and there's a range of organisations, in Wales and sort of across the UK that can help. That are disseminating what they do, whether they're within the health service or can help you understand who is out there in the marketplace. And
we'll be providing some signposting for that, available for anyone who's here. We're going to move into the Q&A now. Before we do, and as I get some questions up, Helen, I think there's something you want to talk about from Health Technology Wales.
Yes, so just a reminder, if you are thinking about a problem that you have and you want to find a digital healthcare solution. Health Technology Wales are at the moment got an open digital health technology topic call. So if you want an assessment of a digital health technology, they're looking for ideas and suggestions of what priorities they should be looking at. So if you go on the health technology website, you say, I need to understand more about this technology or this type of technology, that can go into their assessment process. And they've done a lot of work, for example, really understanding the benefit of flash continuous glucose monitors, a real world evaluation of the impact that that's had. And it's a fantastic piece of work. So not necessarily to that depth, they have different levels but it will give you that insight and knowledge that we were just talking about around what's working and where.
So moving on to our first question. The question asks, we are pioneers in the use of AI in cellular pathology in prostate cancer diagnosis. I'm very keen to develop some tools for colorectal pathology. Is there any possibility of linking AI pathology to radiology and the MDT to speed up the entire process? John, I don't know if you want to say that.
Yeah, I suppose there's perhaps two angles there, isn't there? One is the development of AI models and algorithms, and the other is the front end is seen by clinical teams utilising it. So if we're merging cellular pathology and radiology, our sort of radiomics, I'm only aware of that being done at a sort of academic level to try and sort of, really to start doing that piece about trying to predict often the cellular pathology from the imaging. With varied success. In terms of platforms that try and pull those together, then some of these AI-driven platforms like Dialytics would take the AI-driven outputs from a pathology model, could merge them with the AI-driven outputs of a radiology model and present both those sort of predicted futures to a clinician. In terms of fusing them, I'm not at this stage sort of aware of that.
Yeah, do you think there's any potential for we were talking about designing a sensible pathway around these solutions. Do you think there's something to be said for digital solutions which bring results from, say, pathology and radiology in quickly together to an MDT to expedite?
Yeah, and I think, there are, should we call them MDT streamlining tools like Navify. I think some of that depends on how your MDT functions. The value proposition for some MDTs won't be that high. For others, could be really high, particularly if you've got big geographic spread with imaging done very disparate sort of locations. So I think there's that. I mean, interestingly as well, there are increasing platforms, predominantly in radiology rather than pathology, but it's only a hop, skip, and jump. So, for example, Bayer, the pharmaceutical company, are about to launch a radiology platform that is really a sort of front end for separate AI algorithms. So, for example, you could have a chest X-ray, and running behind that is an algorithm for pneumonia, an algorithm for COVID, an algorithm for lung fibrosis, for COPD. You as the clinician can switch on, switch off which you want. You can see your outputs here. So that sort of merging, I think the world's cottoning on that you can't deploy a single AI solution, time and time again. There needs to be a sort of, we see the same thing at this end, and really in pathology, it's got to be the same, hasn't it? Whether I'm doing prostate cancer today and tomorrow I'm doing my other specialty of gynae or whatever, it's got to feel seamless, not.
Yes.
I think that's you're right that's the way things are going, but it's a real challenge in the way the NHS develops and procures and implements solutions to have a look at that sort of step up, because and you see this in a range of technologies, and remote monitoring is a sort of an example of that right now, where you'll see different teams wanting different platforms that all do the same thing. And how do you make sure you buy something that's that level up that can meet a range of different needs with different modules? And I think that's a real challenge with the way that we buy and implement things.
Fantastic.
Sorry, and I think pathology, but also radiology, there's an element here of what your endpoint is. As your endpoint, you want nudging to a specific diagnosis, and that's quite high end bar for an AI. But is it just normal, not normal? Or, I've seen research evidence, not a product, but, of colorectal sort of, mutation status AI being reasonably good at doing that straight off a straightforward hematoxylin and eosin slide. So again, depends where your backlog is and your problems are. You know, if it's molecular diagnostics, then actually your AI might be at this end through to actually we just want normal and we'll deal with all the not normal.
Yeah. Moving on to the next question. Is there a particular issue with cancer care? There is a worry about privacy steering patients and clinicians away from very simple forms of communication like WhatsApp, Zoom, email.
So I think I personally felt that most communication, if it's worth having, should be going into the clinical record. So, you know, some of those platforms mentioned there are not there's no record of that consultation. Now, I fully accept that sometimes these are pretty benign interactions, but then if it is, why is it happening? Yeah, there should be not, you know, we shouldn't necessarily be needing that sort of level of interaction. So I think there's a what you're trying to do in terms of there are platforms though that, and gosh, fingers crossed this sounds, but like if we move into the world of ambient AI, where your encounter, no matter what setting, will need, you know, will be captured automatically in the clinical record by natural language processing.
So to look at one particular application of it, which I think the question asker might be referring to, there's some evidence starting to emerge about, for instance, using Facebook Messenger with say a chatbot behind it to answer questions about screening services.
Yes.
Do you have any perspective on that as an accessible way in?
Yes, personally, I'm very supportive of that, and I think if we look at how overwhelmed, or sorry, overburdened would be a better phrase, our specialist nurses are, a lot of those things could be handled by chatbots. You know, when's my scan? I've not had the letter, and you know, if we look at mental health services where we have very vulnerable people, you look there, the chatbots in that world are very well developed and are welcomed by patients. They're not for everyone. But if you were able to remove 10% of calls or 15% of calls that actually end up waiting on an answering machine, you're liberating time to care. And I'm actually in conversations in my role at Macmillan around this. I mean, there's some fantastic avatars even out there to be in front of a chatbot. So it's all intents and purposes feels very human. Now we can argue, is that misleading or not? But for some people that'll make it more accessible.
And I think it's also that point around it's not just freeing up clinical time, it's a better experience for patients because they can get an answer when they're really worried, which is usually 11 p.m. at night, not 3 p.m. in the afternoon. And I think it's about what is it that you're trying to communicate? So those simple questions, absolutely, chatbots. I mean, they are used extensively outside of health.
Yeah. And
I think we've been slower to take on because of concerns around patient information and you know, sort of a nervousness around how do we communicate with patients. But you know, in my experience, I get 30 letters a year from the NHS minimum. Most of them are appointment letters. I could have an email, you know, and actually there was, you know, I did get information about a procedure I was going to have by email, which was brilliant because it was on my phone. It meant I could refer to it, and it was a much better use of resources. It wasn't anything that was, you know, sort of confidential. It was information that I was very happy to have on email. So, but then not everyone's going to want it. But I think that we have put that sort of one size fits all. We should do everything on paper. We should send everything out for too long. Yeah. When people don't use those channels, when you think about our daily lives, how many letters do you get? You know, actual correspondence do you get in your daily life now? And I think we need to move our system up to how people are living. I
think the point, and to the person asking the question, get the user's voice in your conversation. You know, when I was clinical director, I managed to engender change by if I align with what patients want, the system struggles to say no. And it's the same if you have a group of service users, patients, carers who say, "I'd love to be able to access a chat." There you go. You know, there's the business case. While still having other channels so people who don't want to use it can still receive the information in a way that suits them.
We're going to move to a very practical question, and I think this is one for John. Given the shift to preventative healthcare, are there any all-round apps that they could promote to patients with regards to promoting healthy living?
Oh, interesting. I think there's no is the simple answer. I'm sure there are, but what I've come across mainly is really that point of teachable moments, and I'm sure a lot of you are aware, the point of a new diagnosis or the point of a health deterioration is a teachable moment. And so, for example, smoking cessation. If you have someone who smokes, at the point of a health wobble, you can leverage a 10% quit rate just from a short paragraph of text. And that's it, because they're psychological. And 10% quit rate is not to be laughed at for a cheap intervention. And so I think this concept of teachable moments goes across all care pathways, and particularly even the point of diagnosis of cancer, the point of commencement of therapies. So I do think we're missing a trick sometimes in leveraging overall health benefits, particularly as we're getting so much better at managing some cancers. We mustn't take our eye off the ball of those being a teachable moment for someone who's got heart failure or got COPD. So there are products out there. One's called Florence. That's a digital app that can sort of do behavioural nudge.
Yeah, through technology. But I think there's also, you see a number of healthy living apps that are quite commercially available. And they're usually around an aspect that somebody wants to change, and then they try and build on that. So, for example, Noom, which is an app which is quite focused around people who've decided they want to lose weight, and then they've built in things around mental health and other sort of healthy living messages around that. Now, some people love that, and some people just want to lose weight. So I think the fact that there isn't a simple solution is probably because we are all individuals and we are all nudged and in different ways. But it doesn't make it easier then to say, oh, this will work. Yeah,
I think if you're wanting an effective tool, you actually have to understand the person. I think there's not just a sort of off the shelf, this gives you some general advice. That will probably only work as well as a leaflet that you used to hand out. Whereas if it's like Quick Genius or whatever it might be, where it's for smoking, it's for addiction, you're giving a slightly more targeted offering. So it's probably about trying to have a shelf of 3 or 4 products that cover the thing, exercise, diet and well-being and addiction or something like that, and then you're covering.
Okay, we've got time for just a couple more questions, but we'll try to get through a bit more quick fire if we can. The first one is a question asking, what is the potential for a single system or even 2 or 3 options for having dialogue with patients and carers, e.g. doctor, My Clinical Outcomes and others via a mobile/tech platform? There's a desire for APIs to be developed to connect to NHS Digital Wales, but perception that patients in Wales still have relatively limited options. So I wonder if you could speak to that.
Oh, well, I think that, all of the conversation we've had today is that you have to start with the problem, and that's coming to the solution. And I think that also means that we won't have an easy, sort of 1 or 2 ways of doing things. I think that, the benefits of digital technology mean that we can do different things in different ways. The challenges are you end up with can be too many systems and processes. And I don't know how we're going to get to a solution. I think that, there is that piece around, if you're looking at communicating between clinicians and patients and, who are receiving telehealth and telecare services, there is a piece around how do we do large scale procurement of platforms rather than products is the way. And then you are minimizing the number of APIs that you're going to need. And there is now an increasing sort of volume of APIs being developed, and Digital Health and Care Wales are doing a lot of work, particularly through the Digital Health Ecosystem Wales, to try and understand what the health boards are needing through APIs and to build those. But there's not going to be an easy answer. I think it's the short answer.
Okay. I've got one final question for you, and I'm going to have to ask you to keep it short. And I'm sorry, because it's a very long question. How do we avoid inequity when we're developing these digital solutions? The elderly, the digitally illiterate, etc.
So I would say that we need to be careful. Not all elderly people have got digital access issues. Digital poverty affects those younger, but I would ask us to reflect on our current inequality of access, geography, bus access, train access. we're surrounded by inequality now. Digital inequality is different and maps differently. And so I would come at this saying, I hope if we overlap them, some of those people who fall through the cracks of digital exclusion are okay because they're not geographically or service excluded. And equally, some of those people who suffer from inequality because of geography or service are picked up by digital. There is going to still be people. I fully accept that, but we hopefully just make that number of people smaller.
Right. Well, thank you so much to everybody who's attended, and thank you so much to John and to Helen for coming along and giving us just a little glimpse of their expertise about how we can start to solve some of these problems in Wales. I've got a couple of things to leave you with before we sign off for the evening. Firstly, we're going to be following up this webinar with a survey, and if you have been inspired by any of the ideas that you heard or interested to hear more on anything, please do get in contact. We are happy to answer any questions about Moondance, about anything else that we've discussed, and to provide signposting for any help that you might require. The last thing that I'll leave you with, and this is an exciting little teaser to give out at the end of this webinar, is I'm really happy to announce that later in July, Moondance Cancer Initiative are going to be announcing a new funding call for innovations and adoption of innovations in early detection and diagnosis of cancer. We're looking for solutions that will be implemented in 2023 with benefits to patients. So if you are interested, please keep an eye on our social platforms. More information will be coming out later in July. With that, I'd like to thank everybody for attending. John and Helen, thank you once more. I hope everybody has a great evening, and thank you for coming.